Welcome, ladies and gentlemen, to another exciting episode of our Expert Online meeting series. We welcome you warmly from our headquarters here in Innsbruck, Austria. And before we get started with this Experts Online on synchrotron imaging, we want to start by giving you a few tips on what you can do to improve your meeting experience. Is this on? Now it's on. So first of all, we would like to ask you to name yourself. You can see on the top right of the screen how to use the Zoom function to rename yourself, add your organization and country. We also ask you to please mute your microphones while you're not speaking to avoid background noise for all the other participants. Where possible, we ask you to please close all other programs to improve the internet connection of your systems. And most importantly, Experts Online is supposed to be an interactive meeting format. And so we would very much welcome your contributions. So please, if you have questions after the talks of our experts, please switch on your web camera and ask your questions to interact directly with our experts, or use the chat function that is also available. You can raise your hand at any time if you want to contribute something to the discussion. We will also be offering English captioning for this event. So you can see in this screenshot here how to activate the closed captioning for this event in Zoom, and please feel free to do so wherever needed. The topic of today's event will be synchrotron imaging, which really gives us a fresh perspective on cochlear anatomy. My name is Daniel Sieber, and I lead the efforts of developing electrodes and surgical techniques at MED-EL Research and Development. And I'm very happy that I have two really excellent experts today with me, Professor Helge Rask-Andersen and Professor Sumit Agrawal, which will talk about their research in synchrotron imaging. Professor Helge Rask-Andersen is a professor emeritus and research director for experimental otology at the Uppsala University and Academic Hospital of Uppsala in Sweden. And Professor Agrawal is a professor and research director for otolaryngology, head and neck surgery at Western University in London, Ontario, in Canada. And we're so happy to have both of them here today with us. But before we get into the talks of our experts, I want to briefly introduce what synchrotron imaging really is. What is a synchrotron device? Well, a synchrotron device historically comes from experimental physics. It's a particle accelerator similar to an X-ray or CT machine, which has very good detectors. It's quite an expensive piece of machinery. You can see a photograph of the inside of a machine hall here. And today it is used in a wide variety of research applications. It is really something like a research factory that is working 24 hours a day, 7 days a week, and is used in many sciences, and particular of interest for us is it's very much used in life sciences as well. The advantages of synchrotron imaging compared to other imaging techniques is that it has a very, very high resolution and a very high image accuracy. Next slide, please. You can see in this picture how even structures that are only a few micrometers thick can be nicely imaged and sharply imaged in a synchrotron image. And the advantage is that we can also do this for larger specimen, such as this mobile telephone, where we can still get this very high resolution, resulting in big amounts of data that we can work on. Now, this is, of course, where it becomes interesting for us with regards to imaging the tiny organ that we are all so excited about, the cochlea. And it's now my great pleasure to introduce Professor Helge Rask-Andersen, who's going to start with the first talk in the series on a fresh view on cochlear anatomy. Afterwards, we'll have Professor Agrawal present on image-guided fitting, and then we'll enter the discussion with all of our participants. So I hand the word over to you, Helge, and we're very excited to hear about your research. Please unmute yourself.
So thank you very much, Daniel. Can you hear me all?
Yes, indeed.
Oh, great. So thank you for inviting me to this webinar and being able to talk about my favorite subject on human cochlear anatomy, relate that to cochlear implantation and to ultramaticity. And since many years, I have been interested in the human anatomy and performed scanning electron microscopy, transmission electron microscopy of the human cochlea, which is, of course, quite difficult to get fresh specimens and good anatomy, and also to section this hard tissue, this extremely hard bone surrounding the human cochlea, which need a special treatment. And here you see this beautiful arrangement of the human organ corti with the 15,000 hair cells with 12,000 outer hair cells and only 3,500 inner hair cells, which is amazing that there are so few sensory cells in humans. And with a razor blade, after the calcification of this kind of tissue, you can get a good view of the complex structure of the small human cochlea. It's only 9 millimeter diameter, and you see these complex fluid spaces with the scala tympani, where we put the electrode, scala vestibuli, and the small organ or corti sitting on this vulnerable basilar membrane. Here you see the cochlear implantations involves basically these spaces of the human cochlea, not the apical third turn. There are 3 turns, as you all know, in the human cochlea. And what we will see is that the spinal ganglion is only 2 turns, which is very essential when it comes to cochlear implantation. And of course, we try to put the electrode in the scala tympani, very atraumatic, and we can see the different sizes of the scala tympani in different turns. And you see the most basal region now is here, 4-8 kilohertz, and we have a pretty large scala tympani which narrows, only after 1¼ of a turn. You can see how it becomes pear-shaped, and it's much smaller, which explains sometimes you get some resistance when you insert your electrode after one turn. And we see the nerve structure sitting in the modulus, the yellow structure here with the 35,000 ganglion cells located here, which maybe we are stimulating them by electricity, or maybe we can even stimulate more peripherally the dendrites that we see out here. The cochlear length is around 42 millimeters, 4 centimeters, the bony cochlea. But the scala media cochlear duct length is only about 33 millimeters, but can vary. It can vary greatly from one individual to the other, which is a kind of problem when you want to stimulate optimally the frequency regions. Now, synchrotron, this is a synchrotron image, and thanks to Sumit, you know, by rare chance, he came to my anatomy course here some years ago, and I was so happy to present the micro CT, so proud, and then he said, well, we do synchrotron. I said, what's this? Show me. And then he showed this fantastic resolution he got back in Canada, and we started collaboration ever since. And that's fantastic for us in Uppsala to have this collaboration with Sumit and with his collaborators. And we can see here a movie where we put these sections into a computer program and make 3D reconstruction. We can remove the bone and we can see exactly the fine details, even the soft tissue. You see the blue folds of the middle ear in 3-dimensionally, which is fantastic for chronic ear surgeons and so on. And we can put in an electrode and we can see exactly how the electrode passes into the scala tympani, how its location in relationship to the lateral wall, which is also a very vulnerable structure that we have to take care of and not to damage in case we want to maintain hearing. And this is a immune section of showing the ATPase, the sodium pump in a human cochlea for the first time, where you can, you know, the sodium ATPase, potassium ATPase is really the motor, the engine of the cell activity. Like in the brain, you know, it consumes 50% of all energy. You can see the red here is more activity, and this is organ of quarter. And the electrode is sitting here, and with very, very little, the very thin wall, even not a real wall against the lateral wall and spinal ligaments. So we have to take care of, and we can see the very high activity sitting in the spinal prominence, also in the stria vascularis and in the organ of quarter, the inner hair cell. So this is very valuable. So now with the modeling, now the human cochlea and the soft tissue, we can now make a tonotopic map of the spine, of the basilar membrane through Greenwich formula, and we can trace back the dendrites all the way to the spinal ganglion and make a tonotopic map also of the spinal ganglion, which is very valuable, of course, for the cochlear implantation. And we see here the funny shape of the basilar membrane here at the base near the round window, which is a sort of a problem for surgically. And here we reconstruct the human spinal ganglion and the Rosenthal canal, and you can see that it's it only turns two turns. It's only 2 turns, and it's much shorter. It's only 14 millimeters, 13, 14 millimeters long. And the peculiar thing is that the first turn of the spinal ganglion is 80% of its total length, but the rest contains even 10,000 neurons sitting here, so 1/3. So it's a very dense area with a large amount of neurons sitting after one turn, which is rather peculiar. Well, because this area, these neurons supplies actually 2 turns, the second and the third turn. So we see that this area is only 2.5 millimeters long and contains 1,000 neurons. Now here we have another cadaver inserted with an implant, We see the silicone coating here, and we can see very nicely the electrodes, and the spiral ganglion has been modeled. And here you see the problem here with this enormously compressed region of the apical turn of the cochlea. Now the bone is removed in the computer program, in the Slicer 3D program, and you can see effectively this tissue without blurring from the bone. And here we can see now the frequency, the tonotopicity, and the frequencies in the human spiral ganglion three-dimensionally. And this was earlier done by Stakovskaya very nicely from histological section, but here you get it from the Synchrotron 3D technique. And you can see now, this is a 26 millimeter electrode, it's not so long, and you can see now some problems actually with the stimulation. You know, you can see this area down here is the 8 kilohertz, 16 kilohertz region, where we often put electrodes, which is actually far beyond the area that we use with the cochlear implants. So the question is, should we put the electrode deeper, or should we have longer electrodes? So that's a key issue. It's a very interesting area histologically in the apex. You know, it's very different from the base, and where we can see peculiar synaptic-like connections between the ganglion cells, which probably has to do with some synchrony, and up here in the apex of the cochlea, where the fundamentals are coded, and the phase locking, you know, is prevalent up here. So we believe that these structures can be involved in some kind of synchrony up in the low frequency region, but this needs further analysis. So looking at the perimodal space, and we follow them, we can see that this is actually the shape of the spiral ganglion in humans. So it goes up about 2 turns, 1 3/4, 2 turns. And so this is a way to if you want to stimulate directly the spiral ganglion cells through perimodal, we should shape it like this to get the optimal stimulation. So when we look at the place frequency, it's important to look at the angular rotation. The angular rotation is most important for frequency localization. And here we just recently performed studies to show the basilar membrane frequencies, the range and the mean at the different angular rotations. And you can see if you want to put the electrode up to the low frequency region, the fundamental regions, you should go at, maybe you should go 2 turns, stimulate if you go along the basilar membrane. And corresponding frequency ranges for the spiral ganglion, what you see is at this region, 720 degrees. So another thing that we just analyzed is the vascular supply, which is of course extremely important for the preservation of linear structures. And we found very interestingly that the Rosenthal canal is supplied by a separate vascular system through the cochlear-vestibular artery and cochlear artery. And there is also a double drainage road and a special road for the Rosenthal canal through the posterior spiral vein. This is the explanation probably that you can get really good, fairly good CI results, even though the cochlea is heavily damaged. So that is the good news for the surgeons. And here is the imaging and the modeling of the vessels in humans. And this study we are progressing, and we have performing further analysis. I don't know if I have time, a few more minutes to speak about, Daniel, you tell me when I should shut up. Say something about the insertion of an electrode in a patient. This is the left side ear, and should we do cochleostomies? Or, well, I guess most of you do round window membrane insertion today, but just to show the cochleostomy effect, which here we see the niche, the round window niche with the typical postis and anterior and postis posterior, and the tegmen and the niche and how it looks. And if you start drilling without taking down the niche, it's very difficult to know where you enter actually. And as you will see, or even if you take down the niche, it's pretty hard. And doing a cochleostomy, well, we have this paper from Boston showing what happens when you do cochleostomies, and there is an inflammatory reaction, usually more or less heavy inside the cochlea, which maybe is not good in the long run. So I think we should all try to do this surgery traumatically. And I guess the best way would be the round window insertion, just to show how nature has solved this anatomy, to have a functioning high-frequency basilar membrane around the human round window. It's very, very, very fascinating. It's through the secondary spiral lamina, which is a kind of almost like a bony or cartilage ridge, which acts as an anchor for the basilar membrane at the round window. And if you sit inside the cochlea looking outside, towards outside middle ear, you have the round window here, you have this suspensory apparatus here, which you easily destroy when you do cochleostomies. And here you can see modeling of this from behind the scala vestibuli with the lamina and the lateral wall and the basilar membrane. And here the light blue, you can see this secondary spiral lamina, which is damaged when you do a cochleostomy. And here you can see with the different types of cochleostomies, maybe this is irrelevant, but I know some surgeons do inferior cochleostomy still, which you can, I think when you do it, you can enter nicely without damaging any structures if you are drilling very far below. But if you look at the temporal bone, inside, outside, and you perform cochleostomies after having taken down the overhang, and you drill extremely inferior. This is very far inferior, almost at the cochlear aqueduct. You see that there is a big risk of damaging, and also the venous drainage. The whole venous drainage in the cochlea goes just side by side with the cochlear aqueduct in the inferior cochlear vein. And the reason why this is so difficult to do it traumatically with an inferior cochleostomy is because you have some ears are smaller than others, and in the smaller cochleas, which is difficult to know from the X-ray, you end up higher up with your inferior cochleostomy. So I think we should try to do the surgery through the round window. I guess you all do that already. So this was the end of the story from my side. Thank you.
Thank you very much, Helge, for sharing this exciting research and these great pictures that are always giving us so much pleasure watching. I would like to now switch the topic. We've looked more on the anatomical aspects of synchrotron imaging now, and now I would like to hand over to Professor Sumit Agrawal, to talk about his research in image-guided surgery based on synchrotron imaging. Sumit, please.
Great. Can you see my screen okay? Perfect. Well, thank you so much for the kind introduction. I do have to acknowledge Hanif Ladak, who's my basic science collaborator and an engineer who runs the lab with me. You've already heard the talk by Helge, but really none of this research would be possible without our collaboration with Uppsala, and a special thanks to Hao Li, who spent literally years of work segmenting all these fine images. And so his work was really critical to all of what I'm going to present to you today. I'd like to acknowledge everyone in my lab. I especially want to thank Alireza Rohani, who is our synchrotron imaging expert. He spent a lot of time at the synchrotron facility getting these images, and Luke Helpert, who is our PhD student, who has done just really beautiful mathematical analysis, and his work will really be the foundation of the talk that I'm giving to you. So Helge's already gone over some beautiful cochlear anatomy, so I just want to point out that our gold standard until now has been histopathology, and that gives us some very nice soft tissue details. But the problem is that these specimens are, they require fixation and decalcification, and that can introduce a lot of artifacts. Each specimen can take months to prepare. 3D reconstructions also have a lot of errors, and it's difficult to localize implants when looking purely at histology. So as Daniel already described to you, we've been doing a synchrotron imaging, traveling to Saskatchewan in the center of Canada, often in the middle of winter, where it's -40°C, to capture these images. And just to give you a sense, this is a clinical CT from a helical CT scanner at 625 microns. The same cochlea on micro CT with 20 microns. You can start to see some of the basilar membrane. And then this is synchrotron imaging, which is not quite at the level of histology, but we're getting to that level where we can really start to see nice, finely defined soft tissue structures. So just to follow up on what Helge was talking about, what about cochlear pitch mapping? So we all know that the cochlea is tonotopically mapped. And unfortunately, when we put in a cochlear implant, there's often a mismatch between where the cochlear implant is programmed and the frequency which the cochlea is expecting anatomically. So what does this mismatch do? Well, we've known from other studies that in patients with single-sided deafness, they can actually have a mismatch of 1 to 2 octaves when you look at the cochlear implant side versus their hearing side. Looking at bilateral cochlear implant users, if there's a major mismatch between the two implants, that can lead to less binaural sensitivity and sound localization. And looking at some really nice work from Charles Lim at UCSF, he's done a lot of work on music perception, and he's found that if you can reduce these pitch scaling errors, those patients have the ability for better music perception. So how do you pitch map? Well, we can use Greenwood's equation. But the problem is, to use this equation, we need to know the total cochlear duct length. And if we know that total cochlear duct length, we can then input, our angular depth or the linear depth and get our actual frequency at that point of the cochlea. If we know that, we can now start creating patient-specific maps. So if we implant a patient, we can actually create a perfect map for their exact cochlea based on their size and configuration of the electrodes. So how do we calculate this cochlear duct length? Well, there's been a lot of work over the last several years on different ways to estimate cochlear duct length in a patient. A lot of the work has surrounded this A value, which is the linear distance between the round window through the medialis to the contralateral side of the cochlea. The problem with this is twofold. One, it's very hard to see that round window membrane on clinical scans. And two, we've done follow-up studies looking at the reliability, which if you have multiple experts, there's often different measurements on the same specimen, so a lot of observer variability. And also that the accuracy of this A value when you compare it to micro CT is quite poor. Now, these equations have been updated. Alexiadis had the initial equations, and Daniel Scherzig did a beautiful ECA equation that actually increased accuracy, and Marcus Piech did some beautiful 3D modeling that also helped with the accuracy of the predictions. But this next slide really shows the problem. Here's two cochleae, and they both have an identical A value of about 8.7 millimeters. So if we look at the one on the right, it has about 2.4 turns with a CDL value of about 33 millimeters. The one on the left has almost 3 turns, and with the same A value, you get a CDL of almost 40 millimeters. So the problem is that if you take measurements along the base, it's very hard to predict what's happening up in the apex. So no matter how much we configure these equations and try to make them better, there's always going to be this variation up in the cochlear apex that hurts our accuracy. So in our current studies, how do we do patient-specific mapping? So as Helga mentioned, Olga Stakovskaya had a very nice paper back in 2007, and she looked at 8 cochleae histologically. So this graph is looking at the distance into the cochlea on the y-axis and the angle of rotation on the x-axis, and she mapped both the spiral ganglion and the organ of Corti. So the one thing you can notice is that for any given angle, there's quite a wide variation in distances, and that's because different cochleae have different sizes. And we know that. So she actually did something quite smart. What she says, instead of looking at the actual distance, what if we change the graph? So instead, let's look at the percentage length inside. So what she assumed is that large cochleae and small cochleae kind of scale to each other. So if you're looking at a 30% insertion, that'll be similar in terms of frequency between a large cochlea and a small cochlea. And as we can see on the organ of Corti, there's much less variation now if we graph the angle versus the percentage length. And this is the graph that many researchers are using for their frequency mapping. So for example, if you take 360 degrees, we can figure out what percentage length that is along the organ of Corti, and then use the Greenwood equation to get our frequency. It's a little bit more complicated if we want to do the spiral ganglion mapping, because you can't plug this into the Greenwood equation directly. So what we do is we go to the next graph, which Helga showed in his presentation. And Olga also did a graph showing the percentage of spiral ganglion length versus the percentage of organ of Corti length. So you can use this graph to map the spiral ganglion to the organ of Corti, and then go to Greenwood's equation to get your frequency. The other thing I want to point out here is that 40% of the organ of Corti maps onto just 20% of the spiral ganglion. So there's a large amount of compression up in the apex, and these are low frequencies. The other problem with the work is when we did a detailed review is that she assumed that all cochleae have about 2.75 turns. So it didn't really look at the different sizes. And there was also not a detailed review of the Helicoptrima out at the apex and the hook region down at the base. So we wanted to take our synchrotron data and do a little bit more of a detailed analysis on these two areas. So let's start with the Helicoptrima. The Helicoptrima is right at the very apex of the cochlea, and it's where the basal membrane ends and the scala tympani and the scala vestibuli meet. So with the synchrotron, we were able to zoom into this tiny piece of the cochlea, and here in green, we can see the basal membrane, and you can see where it ends. And this opening here is the Helicoptrima. And this area should not be included when we're measuring the length of the cochlear duct, because there's no basilar membrane there. So when we took all of the measurements, we were able to take both the linear length of the Helicoptrima as well as the angular length. And we calculated this across all of our different specimens. And what we found is that it had a mean length of about 1.6 millimeters and a mean angular length of almost 70 degrees. So that's the part of the tip that does not house any basilar membrane and shouldn't be used in frequency mapping. And then to do the correction, here we have a linear regression using the CDL calculated out to the bony tip using the lateral wall, or the CDL, I should say, and looking at the CDL just to the tip of the basilar membrane, and we can see there's a nice linear correlation. So using this regression, we can do a nice easy correction. If we just have a total measurement out to the tip, we can correct it for the Helicoptrima. So we thought, how about we do something similar for the hook region? And Helga showed you some nice images of how complicated the basilar membrane is along the base. So currently, when we measure the basilar membrane, we typically start by default or by definition at the center of the round window. And what we ignore is this complicated part of the basilar membrane that hooks around the round window and attaches way down here at the basal tip. And you can see it almost makes a 90-degree turn from where it attaches. So what we did is we measured that hook region and found that that length of the basal membrane is about 3.3 millimeters. And if we compare measurements starting at the actual attachment of the basal membrane to where we typically start at the center of the round window, we can see here's the CDL from the round window, and here's the CDL from the attachment of the basilar membrane. And there's a difference of about 1.65 millimeters. So this correction should also be taken into account if we're trying to find the total length of the organ of Corti. Finally, we also wanted to measure the distance between the lateral wall and the organ of Corti. And the reason is that on clinical scans, we typically only see the bony edge. We can't actually visualize the basilar membrane. So we need to know that distance to correct for that measurement. And so these fiducials in yellow are along the lateral wall. These fiducials in blue are along the basilar membrane. And we took each pair and measured the distance between them. And we found on average across all of our specimens that the distance was about 0.5 millimeters. And that matches with previous measurements by Kawano and other investigators. So now what do we do with all of this data? So now we can go back to our synchrotron imaging. And this is an image that Helge already showed. I just want to point out the dendrites. So these dendrites connecting the basilar membrane to the spiral ganglion across the middle of the cochlea are all nice and radial. So there's a nice linear mapping between where the organ of Corti is and where the spiral ganglion is. There's two areas where that does not take place. One is in the base. We can see that where the basilar membrane makes this 90-degree turn, the dendrites are no longer radial. They have this kind of oblique pattern to them. The second part is up here in the apex, where you can see this large portion of basilar membrane maps onto a tiny little part of the spiral ganglion. So here, again, the dendrites take this long looping course between the two, and they're no longer radial. The second thing I want to point out on synchrotron, if we zoom in, is that here's the organ of Corti again. Here's the spiral ganglion, and here's the dendrites connecting the two. We can see that there's bundling of the dendrites. So this whole region of frequencies all bundle together and connect to one spot on the spiral ganglion. So there's actually this bundling, and this will come into play when we do our mathematical modeling. So now I'm going to get into how we've been working on this new patient-specific mapping formula, and this really has been the core of Luke's work over the last year. So using all of the synchrotron data, we can start to graph this out. So on the y-axis, we have the frequency, and this is the logarithmic scale. On the x-axis, we have the angular depth. And this is one sample, a short cochlea. You can see it's under 900 degrees total length. Here's a larger cochlea that goes out to almost 1100 degrees. We can see another profile. And here's all the samples in between. So we get a very nice amount of data, which is accurately traced using Hao's segmentation of the actual dendrites. So this is true three-dimensional ground truth anatomy. So how do we fit a function to this complicated data? Well, when we're fitting a function, we're trying to minimize the sum of squared errors. And we would think that we want to minimize the frequency error. So the absolute truth frequency versus what our formula would predict. But this may not be the best way to go. And the reason is, if you look at a piano, one octave at the low frequencies may go from 20 hertz to 40 hertz. So a 10 hertz error in the low frequencies is massive. But if we look at the high end of a piano, we're going from 2000 hertz to 4000 hertz. So a 10 hertz error at the high frequencies really doesn't make a difference at all. So if we're just trying to minimize the absolute frequency, we're going to be putting unnecessary weight up in the high frequencies especially. So instead, we thought of using the semitone. So the semitone is regarded to be the smallest pitch difference detectable in non-musically trained individuals. And it's defined as 1/12 of an octave, and on a piano is essentially going up to either the next white key or the next black key. And then this is a formula you can use to calculate the number of semitones between any two given frequencies. So if we look at semitone as our kind of loss function that we're trying to maximize, or minimize, I should say. So we can actually, instead of looking at the difference in frequencies, we can start to look at the difference in semitones. And if we simplify this down, in the end, all of our mapping is going to try to minimize the semitone error across both the whole range of frequencies. So now we're going to come back to our data. And now we've changed the y-axis to be the semitones. And the x-axis is, again, the angular insertion. And this is our smaller cochlea. we could do a simple linear regression, and it's not a bad fit, but you can see there's still this sinusoidal pattern that we haven't accounted for. Here's a larger cochlea, again, coming out to 1100 degrees, and we can also do a linear fit. So the question became, how do we predict the slope of this line? Because we don't know this data a priori. So we want to know, like, if you have a large cochlea or a small cochlea, how do we know which fit to use? So after a lot of trial and error, what we realized is, here's another graph. If we graph the slope that we find on the y-axis versus the number of turns of the basilar membrane, there's actually a nice linear relationship. So we can actually use the number of turns of the cochlea to predict our slope of the linear regression that we showed previously. So if we start making our formula now, we can solve our initial thing for frequency. We can use the y-intercepts of our linear regressions added to the top of the formula here. We can look at the slope based on n, which is the number of turns. And that's the other relationship we showed. And then theta becomes the angular depth that you want to calculate the frequency for. So this will give you a patient-specific frequency using just the linear regressions. So if we come back to our original graph, it'll basically plot something along these black lines. But this still isn't the best fit. Instead of this, wouldn't we prefer to have something like this, where we have all the sinusoidal errors also minimized? So Luke went back to the drawing board and added another sinusoidal correction. And that's shown in this value of C, which is calculated, and I'm not going to go through the math, but based on where you are in the angular depth, we can actually create a sinusoidal correction. So this becomes our final frequency formula for a specific patient at a specific depth. So just creating this mathematically doesn't mean it's validated. So I'm going to spend a minute going over this very busy slide. So these are our 10 samples. And what we did is we did a leave one out analysis. So we created the function using 9 samples and applied it to the 10th. And then we repeated that process 10 times. In the blue is our function, and the black is the Stachowskaya function. The y-axis is your semitone error. Your x-axis is angular depth. So on the top left, we have a small cochlea. And if you look at Stachowskaya's function, as we get out to the apex, she really over predicts the frequency. So we have to apply almost a -20 semitone correction to get the true frequency at the apex. If we go to the opposite side, if we look at a very large cochlea, her function really underestimates the frequency. So we almost have to apply 30 semitones, like 2 octaves, to get the right frequency out at the apex. And now if you look at the blue functions, which is our new formula, we can see that we hug 0 much better across both small cochleae as well as large cochleae. So there seems to be a better fit. If we take this again and we map the error and semitones across the angular depth, and this is averaged across all of our samples, here's the Stachowskaya function. Again, a bit of error at the base, pretty good at the mid frequencies or mid turn, and then again, more error and variation out at the apex. And if you compare this against the error with our new function, we can see that we hug 0 much better across all 10 samples. And that again is using the leave one out error, where the function we mapped to wasn't included in actually forming the functions. So just to finish off, that was the basilar membrane mapping. So what about the spiral ganglion itself? So if we do a similar frequency versus angle of the spiral ganglion, you can see that there's a notched staircase pattern. And we thought this was noise or segmentation error. But what was interesting is we noticed the same pattern on every sample. And this is where that bundling comes into play, where you can see that all of these smooth frequency response on the basilar membrane, unfortunately, gets kind of put into these small staircase pattern because of the bundles of the dendrites. So we're actually seeing this when we map out the frequencies on the spiral ganglion. And that's actually very interesting because the spectral resolution is much more bundled on the spiral ganglion than it is along the organ of Corti. So now if we map all of our samples, we can see this area here, this is the apical compression. So that last millimeter of spiral ganglion maps a lot of our very lowest frequencies along the apex. And so if we just create a scatter plot, we can now just do a simple linear regression to figure out, in general, a spiral ganglion frequency map. Now, the reason that we weren't able to do something a bit more patient-specific on the spiral ganglion is that we can't really predict its length in an actual patient. So unfortunately, the spiral ganglion doesn't correlate well with either the number of turns of the cochlea or the lateral wall length. So on a clinical CT, it's very hard to know how long a specific patient's spiral ganglion is going to be. So that's the reason we just use a simple linear regression for now. And this is the function that we end up with the spiral ganglion. If we look at our errors, again, this is a similar map comparing our equation to Stachkovskaya. We can see it's actually very similar. So we didn't really improve on her work looking at the spiral ganglion work, mapping. And just the very last graph, this is comparing the basal membrane versus the spiral ganglion distribution. So again, here's our angular depth. Now it's on the y-axis and our frequency on the x. This is the base of the cochlea moving up to the apex of the cochlea. So the first thing to point out is along the middle frequencies, the basal membrane and the spiral ganglion map almost exactly the same. And that's because these dendrites are radial. So 500 hertz and the angular depth for the spiral ganglion and the basal membrane are very similar. However, we can see that they really start to deviate as we get out to the apex, and then we really can't use the same map anymore. The second point is that if you look at a 360 degrees, which is a basal turn or one turn, it maps to about 1,000 hertz. So if we want to do anything less than 1,000 hertz, we have to get out of the basal turns. We have to get up into the middle turn or the apex to get any of this low frequency stimulation. So in conclusion, we do have a new patient-specific map, and it seems to work better than the current gold standard. Our goal is to automate all of this with the number of turns and electrode position, and we're currently working on this, and we'll hopefully be able to apply it to low-resolution patient scans. Thank you very much.
Thank you so much, Sumit. This was a very exciting piece of information that you shared there. And before we go into the discussion section of this event today, I want to follow a tradition that's been withheld for every episode of this Experts Online series, which is that we do a group picture. So I would like for all of you for a moment at least to switch on your web cameras so that we can do a little group picture here. And we're very happy to have so many of you joining us today. This is truly exciting. So I'll use the Experts Online coffee mug here for a second and say cheers to all of you. And thanks for being part of this Experts Online today. And I'd be most happy if you could just keep your cameras on, because the stage is now open for a discussion with our experts. And you have the option now of coming forward right away with the by asking directly from your web camera. Please unmute yourself and then ask your questions directly, or the other option is that you use the chat function to contact us directly. Let's see, does anybody have a question right away? I'm sure there are many.
Yes, can I start? This is Peter Knopp from Innsbruck.
Please go ahead.
Rest. Sumit and Helge, thanks a lot for your talks. As an engineer, I'm really impressed about how much you know already about the cochlea and how much we can still learn, especially for cochlear implants. Now, Sumit, one question. If I got you right, then the patient-specific mapping formula that is a relationship between the number of turns of the cochlea and the frequency mapping along the cochlea, that would somehow replace Greenwood, correct? And if so, would it make finding out the frequency situation in the cochlea of a specific patient, would it make that easier in relation to what we have now with Greenwood, or would it make it more complicated or pretty much stay the same? in other words, is the number of terms easier to find out or to measure than cochlear duct length?
So our formula kind of needs to use Greenwood to actually do the initial mapping. So even with Greenwood's formula, you need to know the total cochlear duct length. And the problem is, how do you extract that? So the advantage of our formula is that it'll give you a specific frequency at any angular depth, as long as you know the number of turns of the cochlea. So both of them are a little bit difficult, because either you need to know the number of turns of the cochlea, and then you can actually get the specific angular frequencies, or you can use Greenwood's from scratch, but then you need to know the total cochlear duct length. So ours is more practical for cochlear implant mapping, because you can say that this electrode is at this many degrees in, and I want to find the frequency for that particular electrode, for example, taking into consideration all the different corrections of the Helicoptrima, the hook region. Everything's been taken into account in that one formula, essentially. I think you're muted. Oh, sorry.
Sumit, hi, Michael speaking.
Yes,
Michael,
I was
you have
muted.
to clap down your microphone, please.
Sorry. Yeah, just may I have a question exactly to that when it comes to electrode design. So is that independent from the design, let's say, from free-fitting electrodes or modular hugging electrodes? Is there then generally a difference when you apply those formulas?
So the big debate as to where you're stimulating. Are you stimulating out on the organ of Corti, or are you stimulating actually the spiral ganglion itself? Our formula definitely is much more accurate looking at basilar membrane mapping, which is a much more continuous map, and there's more spectral resolution at the apex. So it's much more accurate kind of for the frequency along the basilar membrane. But we do have a linear function also for the spiral ganglion. But that map is not as accurate. One, you have the staircasing, you have the bundling of the dendrites, and you have all that compression at the apex. So even though you can predict the frequencies, it's not going to be as accurate.
Thanks.
Yeah, I mean, this is a question that I also I mean, it seems like, first of all, from what you both discussed today, I think, Helge, you had a very interesting table on that also. It seems that when we're talking about insertion of cochlear implants into the organ, we should really talk more about angles, right, versus millimeters. Because it seems like there's a pretty big difference in angles per millimeter in an individual anatomy.
Yeah, yes, angles is better than the absolute lengths. We can see the lengths of the human cochleas can vary quite a lot, as we already know, up to 1 centimeter. The angular rotation is much more similar. What we also see is that the basilar length, the basilar membrane length, the total cochlear length is very variable. But when we look now on 10 human cochlea, look at the frequency bands of the spiral ganglion, they are actually pretty similar. There are much smaller variations in the tonotopic bands of the spiral ganglion, which is a little bit interesting.
Yeah.
But there is some variation, but it's not as much as the basilar membrane.
And it seems to me that probably the cohort that we're stimulating has changed quite a bit over time, right? Whereas initially, most patients that were stimulated had a very severe hearing loss, where the majority of patients these days has some degree of residual hearing. Would that change our anticipation of the functionality of dendrites in the second term?
Yeah, yes, this is very essential. Most patients with age-related sensory hearing loss, presbycusis, and many patients, they lack urines in the base of the cochlea. The question is, how much should you stimulate in this you should say, the dead region, which is very difficult to know if it is really a dead region, since you can actually still have preserved neurons with the new dendrites, and which are still excitable with the cochlear implant. But you know, we have a large population of patients where we have an accumulation of neurons more apically, and therefore that would be suitable to stimulate them electrically further up in the spinal ganglion region. But unfortunately, we don't really have a preoperative tool to really know about this, because the audiogram doesn't give us exactly the situation, the anatomical situation in the cochlea in any of the patients.
Sure. So that's what we have to work on, I guess.
Yeah, that's exactly we should do synchrotron analysis in human clinically, but it's not possible, as I understand. I ask Sumit all the time, can't you put it into the clinic? But I don't think they have the space there to put all these.
And I think it might be terminal examination also.
Yeah, but maybe in the future we could see a much better, even better resolution, or at least like the micro CT image in the patient. That would be fantastic.
Okay, do we have any more questions from the audience at this point?
I would have one more, maybe to Sumit and Helge. So we were talking about the A and B value, and that it can be hard to detect, or there can be some inter-observer variability. Do you think that from an expert observer, maybe from the two of you, if I gave you a clinical CT, would you be able to accurately detect the number of turns, measure the number of turns, or do you think there are algorithms that could help doing such a thing?
Yeah, so doing it manually is also kind of difficult, because you have to get the mid-mondicular axis, start at the round window. So, but what's interesting is that on cone beam CT, you have enough resolution to measure out to the apex and get the bony definition. So our goal is to automate it. So rather than having a person sitting there trying to measure the number of turns, it actually extracts the cochlear cast of the outer shape of the cochlea, which is actually quite easy to do because it's within bone. And then actually just import that cloud of points into MATLAB, and then actually just doing more automated measurement. Similar to kind of what Marcus had written with his really nice analysis of his kind of cochlear shape. So I think that's a really nice project to be able to do in an automated fashion and get rid of the whole expert variability altogether.
Makes sense.
At worst, maybe the expert could just define the bony tip with a single fiducial just to define the endpoint if needed, but I don't even think that'll be needed with the clouds.
Okay, thank you.
Is there time still for one more question?
Sure, please go ahead.
It's just giving this very nice detail of synchrotron data. Sorry, I can't switch on my camera. How do you see the modeling capacity really you said that we are working on model to translate this high resolution also to clinical data, like to low resolution clinical data which we can get for patients. Like, what do you think is realistic in the next years? What detail you can get from the clinical data based on your nice synchrotron resolution?
So the nice thing is that using these formulas, as long as we can get the number of turns of a target cochlea, we should be able to apply our formulas pretty well. So we're right now using some deep learning algorithms to extract the cochlear shape, and we've already been successful at that. So the next step, hopefully in the next 6 months, is to create the model which can use that cochlear shape, extract it, whatever variables we need, and then apply the formula to it. So that's actually not very far off. We're hoping to get that done in the next 4 to 6 months.
Okay, thanks.
We also have to consider that many cochleas have a very peculiar shape. You know, the different turns are angled against each other and so on. So that is a problem. You really need to have a technique to save residual hearing because that has a great impact for saving in-ear structures and doing it dramatically. You know, the turns can be very peculiarly located in relation to each other, which is very difficult to see on the clinical CT. But in the future, maybe we will be able to do that with better imaging techniques and higher resolution.
Can I ask a question, Daniel?
Please go ahead.
Peter? Yeah, okay. When we then come to assigning to a frequency to a certain electrode on the array from the post-op on the post-op CT or from the post-op CT, there are two parameters that are really critical in relation to that frequency, and that is that's the dimensions of that's the two structures that Sumit mentioned, and that's the dimensions of the Helicoptrima and the dimensions of the hook region. Once those are fixed, I guess, then also the angle frequency relationship for a certain electrode contact in the cochlea is fixed. Now, can I ask, do you think you're now at the ultimate or final truth about how big the Helicoptrima is and how long the hook region is, or is there some uncertainties in those two structures still?
I mean, like from the synchrotron data, I think we've gotten probably the best data to date. It's a three-dimensional model of the Helicoptrima and however many samples we had. I think we had 14 samples in that analysis. It's better than histology, because in histology it's very hard to measure the three-dimensional size. I don't really know how much better we're going to get. We already have a pretty good average, and we have pretty good linear regressions to model both of those regions. So I'm not sure how much more data we need for the basic cochlear implant programming side, at least.
Yeah.
I'm not sure if Helge has any other anatomic considerations, but I think from a pure mathematical point of view, we have the data that we need.
Okay. Can I ask, in the patient-specific mapping formula, do you use average values for the Helicoptrima or the hook region, or is it the actual value in a sense?
It's
for the
actual
Helicoptrima and the hook region in a patient. So do
Yeah,
the Helicoptrima and the hook region, do they scale with the actual dimensions of the cochlea, the length of the cochlea or something like that?
Yeah, so the hook region is surprisingly stable, right, across our samples. And then the Helicoptrima has a kind of a linear scaling based on the bony lateral wall length. But in our analysis, we actually didn't have to use a fixed value because each specimen had its own exact mapping based on the dendrites.
Right.
So
Okay.
all of that was taken into consideration in the raw data. So we actually fit a function on those 10 samples based on the raw dendritic mapping that Hao and Helge did in Uppsala. So we didn't have to use averages. We didn't have to use extrapolations from the linear regressions. We actually used like raw dendritic mapping to create all of those.
Right. Okay. Okay.
Okay,
Okay,
we have a question that came in from through the chat from Germany, and I think it's directed at Professor Rask-Andersen. It's regarding the anatomy and the arterial blood supply. So, is there an explanation why, in several cases of hearing loss, such as sudden hearing loss, there is more residual hearing in the low frequency region? And I guess the question is whether it could be related to the arterial blood supply.
Yes. You know, the cochlea in the human is supplied by cochlear-vestibular artery, which goes into the cochlea at the basal region, and then the cochlear artery, which goes into the cochlea around 3/4 of a turn up. So the apical part with the low frequency hearing is mostly supplied by the cochlear artery. So you could imagine that you have a vascular strangulation or ischemic condition in the cochlear-vestibular artery that supplies the basal high frequency region of the cochlea. And that also supplies the saccule the vestibular part. So if in case you had some vestibular disturbances, in addition to the high frequency loss, that could support that there is some problems with the circulation of the cochlear vestibular artery. To follow these arteries is amazing. Amazing how they enter into the cochlea through these bony holes, perforations into the cochlea. And it's amazing to see. It should be very vulnerable, you would think. And you also think that the supply is not that fantastic, and still it works so well. It just fascinates me, and I get the impression that we have a lot of cochlear pathology that is caused by vascular disturbances through these two arteries, and we are just in the beginning of looking at the anatomy of these vessels and how they distribute inside the cochlea. They're extremely complex, and not speaking about the venous drainage, which is also fascinating. A fascinating pattern of flow, which is different from many laboratory animals studied by many famous researchers over the time. So that we can get a good appreciation of the human situation, I think is very, very nice, very, very fantastic. And the problem is, of course, to see the very small vessels, the capillary region we can't really see in the lateral wall, but we can see the main trunks and how they course inside the meatus, with some anatomical variations. And here we need to use some staining and some increase in contrast imaging to really see their anatomy. This is fascinating, and then anatomical variations are quite extensive also. So this is a fascinating area.
Thank you so much. I think there's just another question from the chat that's directed at you, which is, again, considering the delicate vascularization of the cochlea, particularly in the around the round window region, do you expect that damage to the residual hearing and the function of the stria vascularis could be caused independently of electrode length? So I think this relates to residual hearing again. Could loss of residual hearing already be caused by the first few millimeters of electrode insertion, or maybe the access itself?
Low residual hearing is mostly low frequency hearing, and so the first portion of the cochlea would not be that critical. The only thing you shouldn't do is to obstruct the venous outflow through the inferior cochlear vein, which goes in the floor of the scala tympani, just inside the round window. But the risk of that, I think, is pretty small, and you need to have a really big, huge, broad electrode to obstruct the venous outflow. So, and the nice thing in the scala tympani is that the venous flow goes always through the scala tympani, while the arterial supply goes through the scala vestibuli. Mm-hmm. So you would not damage any arteries if you don't perforate the lateral wall, which of course you can easily do if you have a traumatic technique, and if you do a cochleostomy, anything can happen, of course. But I think cochleostomy is not a hearing preservation technique. I don't know how many use it today in hearing preservation surgery. I know that some surgeons claim they have excellent hearing preservation results with cochleostomies, but I doubt that this is a good technique to have a long-run preservation of inner ear function. Many of the patients, maybe they were operated through cochleostomy, maybe they had some low frequency hearing, and maybe actually this hearing could be saved even though you damage a large part of the basal cochlea, because there is a lot of longitudinal or radial flows along the cochlea. In the long run, we see these inflammatory changes developing over time, inflammation and so on. Inner ear is very, very sensitive to trauma. You know, we find now these immunocells, innate cells that are present in the human cochlea, which are there to protect the ear, but they can also cause a lot of damage by inducing inflammation. So we have to be really careful when we do this surgery and use probably anti-inflammatory agents in connection to soft surgery when we are operating patients with residual hearing.
Thank you very much. Yeah, that's very good thoughts. We're coming, I guess, to the end of this session. I have one more question here in the chat that I think is related to Sumit, and it asks whether how helpful this technique, and I assume the model is meant here, is with deformed cochlea. Can you comment on how your learnings would apply to malformation cases?
I mean, that's a great question. It's really designed for normal cochlear morphology and shape. I mean, if you just have a mild Mondini where you still have a normal basilar membrane length, then you're still going to apply Greenwood for the function. It could technically work, but it's really designed for, you know, our mapping is really between like 2.4 and 3 turns. That's where we did our function. So anything outside of that is going to be an extrapolation that we haven't validated internally. So we think we got the range of normal cochleae when we did the function, but once you get into abnormal or deformed cochleae, one, we don't even know what the basilar membrane is, and the more deformed it is, we don't even know what the map is supposed to be. And two, our equation won't really extrapolate. There won't be any validation to extrapolate it to really small cochlea, for example.
Thanks, Sumit, for this clarification. I think we have to end here. It was, I think we could continue this discussion for a long while, but we've exceeded our time limit already. I would like to thank our experts very much for contributing to this Experts Online today. I would like to thank all of the participants. If you liked this Experts Online, then I would like to highlight that we have another Experts Online coming on October 7th, same time again, and this is going to be on image-guided surgery and the future of cochlear implantation. Thank you all so much, and see you soon. Take care.